Good evening, everyone. We welcome you all to Ortho TV online in India, and good morning, everyone, to the other part of this world from Brazil. So this is the fourth Indo-Brazil webinar on a topic which is very close to my heart, which is related to technology. So today we are going to talk about augmented reality and 3D printing. And to introduce today's faculty and the detailed topic, I hand over to our moderator, Dr. Sergio Rowinski.
Okay, so let's go. Okay, so hello, my good friends. It's a pleasure to be here. For those who don't know, the majority of the people already know me. I'm Dr. Sergio Rowinski from Shoulderplanet, here from the city of São Paulo, Brazil. And it's a pleasure to be here. This is a lovely webinar, a very good one, because this is our fourth event, Indo-Brazilian shoulder webinar between Shoulderplanet and Ortho TV. But this is the first one in which we are discussing something new that goes much beyond the shoulder and elbow universe. And now we are expanding this project and this endeavor to the whole orthopedic. So today we are talking about something that's very nice, and that's not a fantasy, that's not Star Wars, that's not Hollywood, is a reality, which is 3D planning and 3D virtual reality and 3D printing in the whole field of orthopedics. So I have very good guys with me now. They are all my friends. I'm gonna introduce them fastly, and then I just want them to say hello, and then I'm gonna tell you guys the sequence of the event, and then we can start. So first of all, we have here an outstanding orthopedic surgeon from India, my beloved India, Dr. Lalit Maini. Dr. Lalit Maini, hello, sir. It's a wonderful, it's a wonderful trauma guy. He does hips, knees, complex osteotomies, complex trauma. He does also some tumors, and he is one of the most relevant guys in Central Asia about 3D printing, and it's a pleasure to have you here, sir. You're our new friend, and this is an honor. From Brazil, we have two guys. From the south of the country, my good friend, Dr. Bruno Gobbato, which is a shoulder and elbow surgeon just like me, but he has been developing a personal job in 3D printing, in 3D planning for about 10 years. He's been doing this in his house, and he's a very self-made man, a very curious man. And he has become very, I would say, in a very easy way, one of the most relevant guys in all of these topics in the whole Brazil, and I dare to say in South America. He has already presented some lectures to other European countries, Germany, if I am not wrong, but and others, but Germany. And the nice thing is that in spite of being a shoulder and elbow guy, the majority of the things he does in 3D printing is not in the shoulder and in the elbow. It's in the other things, and this is why this is very important for everybody in the field of orthopedics, but he is also a shoulder and elbow guy, a very talented surgeon. And my good friend who is becoming a veteran of this project, Dr. Ildeu Almeida, which is my good friend. He lives in another city, 500 kilometers from São Paulo, Belo Horizonte, the city of Belo Horizonte. He's a shoulder and elbow guy, very talented surgeon, lovely academicist. I always say this point. He was the president of Brazilian Shoulder and Elbow Society last year, and he was one of the organizers of the World Shoulder and Elbow Congress, together with our good friend, Dr. Daniel Moya, and he's a good friend of Dr. Daniel Moya. So we are here as a brotherhood, which is very good, and the brotherhood is expanding all of the time. So before I say the sequence, I just want you guys to say hello. So Dr. Lalit, you are the first because you are our super international star, sir.
Thank you, Sergio. Thank you for those kind words. It is a pleasure to be on the planet, and especially on Shoulderplanet.
Thank you.
Greetings to all those who have logged in from all over the globe, and special greetings to people who are becoming technology enthusiasts and trying to integrate beyond orthopedics. So as Sergio already told, I've been into this for some time now, and I keep sort of trying to explore more. Sorry.
Yeah. I guess I'm
audible. Yeah.
Okay.
So thanks a lot, and probably as we go on in this webinar, we'll get to know what all we do and how we are trying to explore other areas of technology to incorporate to improve healthcare. So very happy to be on Shoulderplanet and with all of you together.
Thank you, sir. Dr. Bruno is our South American star. Now it's your time to say hello.
Thank you, Sergio, for the kind words. It's a big pleasure to be here with broadcasting actually from the other part of the world and for the whole world, for the whole Shoulderplanet world. Thank you very much. It's a pleasure to be here. Hope you enjoy.
Oh, everybody will love it. You are one of the big stars. And see, Dr. Ildeu is becoming a veteran with me. He has been supporting me since the beginning. And this is an honor to me. And he's a very elegant man. And I just want him to say hello before we start.
Thanks, Sergio. I would like to thank you, Ortho TV, Shoulderplanet, and mainly the orthopedic world surgeons that are participating in this important webinar. I'm very anxious to see what these guys are going to do. Thank you for the invitation.
They are going to make our minds get crazy. This is the intention. So see, friends, this is what we are going to do. We have about 2 hours here, maybe a little bit more. And I guess we are going about 20 to 30 max, but this is how we have been doing. This is going to be quite interesting. We have 3 lectures and then at least 40 minutes for discussion. Dr. Ildeu has, as I said, he's a shoulder and elbow guy. He has a lot of experience in arthroplasty, so he will give us a lovely lecture, about 20 minutes, in biomechanics of the shoulder and how to understand anatomy and biomechanics to shoulder arthroplasty. And this will give us subside to understand the 3D planning. And then we come with Dr. Lalit, and after that, Dr. Bruno. This is going to take about, I guess, 1 hour and 10 minutes, something like that. And after that, I hope we have at least 40, 50 minutes for discussions, okay? So it's a pleasure to be here with you, my good friends. And Dr. Ildeu, so now you can share your screen and let's talk a little bit about biomechanics, anatomy, and how to understand it and to apply to shoulder arthroplasty. And after that, we start with 3D printing and virtual reality. So that's it. You can start, Dr. Ildeu.
Thank you very much. I'm going to talk a little bit about shoulder morphology and biomechanical implication of it. So, the degenerative joint diseases, they have different causes: genetics, morphological, and secondary to rotator cuff tears, infection, inflammatory diseases, post-traumatic, and instability. So during residence, we are taught that for primary arthritis, we have to do an anatomic total shoulder replacement for advanced cases. And for rotator cuff arthropathy, we are supposed to do reverse arthroplasty. So, but we have different evolution of these pathologies, and we need to understand the changing in morphology to plan the surgical treatment. So when we have primary glenohumeral arthritis, we have big osteophytes, and we have posterior subluxation. And when we have rotator cuff arthropathy, we have cephalic migration of the humeral head, so superior subluxation. and we still have posterior subluxation as well. So the glenoid inclination during this evolution process is different in both cases. So we have a podalic glenoid facing the floor on the left side, and the cephalic glenoid facing to the top on the right side. So to plan the surgery, you have to understand the deformities first. So, and there is an association between the individual anatomy of the scapula and the development of the rotator cuff tears or osteoarthritis. This paper showed us that the critical shoulder angle is an important way to tell the patient if he or she is going to develop arthritis in the future or rotator cuff tear. So if you have a big critical shoulder angle, which means greater than 38 degrees, you are going to have probably a rotator cuff problem in the future. And if you have a small angle, which means less than 32, 34 degrees, you are going to have probably arthritis. They have changed, they have tried to understand another index or another angles to understand what's going to happen with the shoulder. But the critical shoulder angle was the best one in the compared study. So it's important to use the critical shoulder angle to predict the healing process as well. So you have a big critical shoulder angle, you are supposed to do a lateral acromioplasty to avoid less healing and to avoid re-rupture, because the incidence of re-rupture, if you have a big critical shoulder angle, is 4 times more than the normal critical shoulder angle. And we are not supposed to use MRI to calculate the critical shoulder angle. We are supposed to use AP view on the X-ray to do it. So let's talk about basic principles, the differences between anatomic and reverse prosthesis. For that, we have to understand the concept of center of rotation. Center of rotation is a fixed point in a moving body. So velocity is 0. And in normal anatomy, we have the center of rotation in the middle of the humeral head. But when we are going to do a reverse prosthesis, the center of rotation changes to the line of the glenoid. So it's medialized. In this way, we have advantages of medializing the center of rotation. And the advantages are, we have a greater lever arm, we have more deltoid activation, and we have better glenoid fixation. So let's understand why. On the left side, in figures A and B, we have a normal shoulder, and the center of rotation is in the middle of the humeral head. So during abduction, we are going to use parts 2 and 3 of deltoids. But on the right side, doing a reverse shoulder arthroplasty, medializing the center of rotation, now we can use more parts of deltoids. So medializing the center of rotation increases deltoid muscle activation and strength. So what about torque? Torque is the ability of a force to produce rotation. So when we medialize the center of rotation, we increase torque. Deltoid has to be tensioned to work properly. So the inferiorization of the humerus gives more strength to the deltoid. So it's important to medialize and to have inferiorization, distalization of the humeral head to increase deltoid tension. So all these concepts, they were established based on biomechanics laboratories. But medialization and distalization has disadvantages as well. So we have a shortening rotator cuff after medializing too much the center of rotation. And in this way, we are probably going to have increasing scapular notching or decreasing deltoid wrapping and decreased stability. So we need to understand that we have to do something after medializing too much the center of rotation in order to give the patient the opportunity to establish the external and internal rotation. So how can we do that during the surgery? You can use an allograft and on the base plate to lateralize a little bit the center of rotation, increasing the tension of infraspinatus, teres minor, and subscap. If you are doing a primary procedure, you can remove the graft from the humeral head and put it in the base plate. So if you are going to do a revision procedure, so you do not have the humeral head, or if you do not have a bone bank, so you can use a metallic increased offset reverse shoulder arthroplasty. Another option is to use a bigger glenosphere. So there is a classification for the glenosphere. So we have to understand the distance between the center of rotation and the glenoid border. So if we have the distance between both less than 5 millimeters, we are going to have a medialized glenosphere. If we have more than 5 millimeters distance between the center of rotation and the glenoid border, we are going to have a lateralized glenosphere. Despite of the fact that we are trying to lateralize a little bit the center of rotation, it is still medialized when compared to the normal anatomic center of rotation. And we have different designs. So classifying the different styles of design allows surgeons to discuss the degrees and the potential of biomechanical consequences of implant selection for patients. So here we have to understand the concept of humeral offset. It's the distance between the longitudinal humeral axis and the line parallel from the liner center. So there is a classification for that as well. If we have this distance less than 15 millimeters, we are going to have a medialized stem. But if we have a more than 15 millimeters distance, we are going to have a lateralized humeral stem. So have a look. Here we have both. We have the medialized humeral stem and the lateralized humeral stem. So the Grammont prosthesis, which is on the lateral side, the left side, and the new designs on the right side. So on the Grammont prosthesis, the cut, the neck angle, the cut during the procedure is at about 155 degrees. But in the new designs, the cuts are from 135 to 145, lateralizing a little bit the humeral stem and the humeral bone. So another important concept, it's about inlay and onlay. What's that? We have to understand the contact between the glenosphere and the polyethylene. If the contact between the glenosphere and the polyethylene is inside the bone, we have an inlay situation. But if the contact between the glenosphere and the polyethylene is outside the bone, we have an onlay prosthesis. And having an onlay prosthesis, we are going to have less impact between the humeral bone and the neck of the glenoids. So we have lots of different ways of doing the prosthesis. So it's difficult sometimes to understand which is the best for our patients. But talking a little bit easier, we have to, we can do a straight humeral stem or a curved humeral stem. If we do a straight humeral stem, we are probably going to have a medialized humerus. If we do a curved stem, we are going to lateralize it a little bit. And so now here we have two prostheses, the Grammont, the one with a medialized humeral stem and a medialized glenosphere. On the right side, we have the modern type design, which we have a lateral humeral component and the lateralized glenosphere. Well, but we have to understand the normal anatomy before doing this 3D printing. So this paper showed us that there is not 100% contact between the humeral head and the glenoid in normal population. So there is a tendency of posterior subluxation, even if we do not have any pathology going on. So the normal contact between the glenoid and the humeral head is from 48 to 62% of humeral head subluxation. So this is the normal. And Gilles Walsh has established a very good classification for the glenoid defects regarding this posterior subluxation. And we are going to talk more about the type B2. And you will understand why, because it's the most common one. So this paper changed concepts. Why? They have done a systematic review and they have operated 239 patients doing an anatomical total shoulder arthroplasty in patients with B2 glenoids. And they found 42% of loosening. This is really unacceptable. So 42% of loosening. And when we study a little bit more this loosening, the revision rate was 15.6% for asymmetric rimming. So the technique used during the procedure to compensate B2 was rimming. So 15.6% of complication. 9.5% of complication revision rate for posterior glenoid bone grafting, and 0% of complication using posterior augmented glenoids. So this is a very good support for trying to do 3D printing and develop customized prostheses for our patients. Well, if we have more than 10 degrees of retroversion, we are going to have a high incidence of loosening. And here we understand why. Because we are going to have eccentric loading and early glenoid loosening because of that. So if you have more than 10 degrees of retroversion, we are not supposed to do anatomic total shoulder replacement for arthritis anymore. So that's why the concept has changed. So we are supposed to do reverse prosthesis with some kind of compensation, augmented glenoids. But if you are going to do a rimming, you do not have technology to do augmented glenoid. So you have to understand that you can't leave less than 15 millimeters in the scapula. Otherwise, you are going to perforate the scapular body. But if you use a bone graft, a structural bone graft in the posterior side, you are probably going to have failure because there is a high rate of complications using posterior bone grafts. You have recurrence of instability and you have subsidence of the graft, absorption of the graft. So we are supposed to use augmented or wedged glenoids. And it seems that the wedged glenoids are better than the augmented ones because of the forces distribution. Well, what about doing a reverse in B2 glenoids? What about the results and the incidence of complications? Because for total anatomic replacement, the incidence of complication was 42%. And here they have done 27 reverse shoulder arthroplasties in a follow-up of 45 months. And they found 15% of complications, which is acceptable. So let's talk about the golden rules for anatomic shoulder replacements. Because if you have less than 10 degrees of retroversion, if you have less than 10 degrees of superior inclination, and if you have less than 80% of scapulohumeral subluxation and 80% of full contact between the base plate, in this case, the glenoid and the native bone, minimal rimming, and you are supposed to do a total shoulder arthroplasty, anatomic one. And we have lots of different implants. So it's difficult to choose the best one for our patients. So I'm finishing now because we have a few time, but I need to talk about this a little bit. Do the design change complication rates? So the incidence of complication in the beginning of reverse shoulder arthroplasty was at about 33%. So unacceptable. So based on this publication of Mayo Clinic, now using modern designs, we have 2.37% of complications. So that's very, very acceptable. So the conclusion is that the primary prosthesis using modern designs leads to low complication rates. Thank you very much for the opportunity.
Hello. So everybody see, Dr. Ildeu, very nice. I love it that you see, as a shoulder and elbow surgeon, if it depended on me, we would keep the whole webinar only discussing these things. But I don't want to keep this as a super shoulder and elbow stuff because we have many general orthopedic surgeons here in this area. I just want to mention two things. Dr. Bruno, can you stop sharing your screen for a moment? Dr. Lalit, can you stop just for a second, sir? Because I would like just to highlight some points. Dr. Ildeu, your voice is off. I just want to mention some important points for us before we continue. So the thing is, what Dr. Ildeu has shown us is very important, but I think there are, at least in my point of view, two messages for the general audience. And I just want Dr. Ildeu to comment upon it fastly because I want general orthopedic surgeons to fix important concepts in their minds. So the first one is, Dr. Ildeu was talking a lot about the superior subluxation, which is in the end anterosuperior scape. So anterosuperior scape is a phenomena when you don't have the cuff and you have the superior migration of the humeral head. And this is when all of the rotator cuff arthropathy, starts. And this happens essentially when the subscap is also gone. But I think that the message here is that whenever you have a normal glenoid, doing a shoulder arthroplasty is much easier. And whenever you have a big defect, especially in B2 glenoids, this is when we have space, a lot of difficulty and space for 3D printing. So in summary, 3D printing helps us too much in the shoulder arthroplasty, much more in the glenoid defects than with any other problems with the humeral head. Yeah, and I just want Dr. Ildeu to comment on that because this is very easy for us shoulder guys to understand. But if you have a big fracture sequelae and the glenoid is quite preserved in the CT, it's much easier for us. I just want Dr. Ildeu to highlight to the general audience this idea because this is very easy for us shoulder guys to understand, but I want them to understand, to know where we have the role of 3D printing in shoulder arthroplasty. So I just want Dr. Ildeu to comment upon it.
Thanks, Sergio. I would like to say about indication of the arthroplasty. So in the past, we delayed too much. We expected the patient to be having pain, quite a lot of pain to indicate the procedure. But now we understand that deformities, they are important to the survivorship of the prosthesis. So okay. Now I would suggest us not to delay too much the indication. So this will be easier for the surgeon and the survivorship of the procedure will last more. So that's one message. And the other one is I didn't talk anything about fractures, But
Yeah.
there is a very high tendency of doing reverse arthroplasty for complex proximal humeral fractures in old patients. So the 3D planning is very useful in these cases as well. So I'm expecting Dr. Bruno and Dr. Lalit to talk about this.
Okay, lovely, lovely. This is another idea that people have to understand. The indications of reverses in elder people in proximal humerus fractures is increasing too much. And the planning of that is very important. In these cases, we don't have so much complicated glenoids, but many times things go very difficult. And this is the moment when Dr. Lalit and Dr. Bruno become so important. So this is a message that I want people to understand. Dr. Ildeu has beautifully said that. So now we will start. Dr. Lalit, can you start now, sir? And then Dr. Bruno.
So is my screen visible?
Yeah, I just would like, sir, I just would like Dr. Bruno to stop his camera because it eases the internet for Dr. Lalit. Dr. Lalit, you can start, please.
So now we would talk about 3D printing in orthopedics. The application of this technology in all type of problems in orthopedics. We have been using this technology, and with years passing, we have been able to understand and make it a more useful tool. So let us understand some basic thing about this tool. Now, man, when he was in a jungle, he made some tools. Through those tools, he was able to get his living, he was able to get his food, so he became a superior animal, if you can call him. So that is where the journey of human race started, when we started making tools. And not till very much past, the tools have been made by machines. And then the next step was the machines were connected to computers. So now the machining part, as you can see in the top diagram A, this was the normal manufacturing process, which was called subtractive manufacturing, meaning you would subtract the tool which you want out of a block of material. And in that process, as you can see, there would be a lot of waste. And in making these tools, you will be using the same drills and burrs of the machining industry, and they would be guided by computers. So what has changed? It has changed from subtractive manufacturing to additive manufacturing, meaning that from the material, layers are laid down. As you can see in the picture below, the B, layers are laid down. By addition of layers, the structure of the tool is made, and there is hardly any waste. So this is the new technology of additive manufacturing, which is also the other name for 3D printing. So putting it in orthopedic ways, if you have to 3D print a femur or manufacture a femur, you can do it by subtractive manufacturing, meaning you take a block of material and then start carving it, and gradually you are left with the femur, and the remaining material is a waste. Or if you see in the picture below, the bottom up process, meaning additive manufacturing, you start laying down layers in the exact shape of the femur. And at the end of the process, you get a whole femur made without any material wasted. So let us look at a short video on the basic steps to do 3D printing. It's very easy. You need to choose a software, do some virtual planning, and make an STL file. If you are not very good in the beginning, you can go on Google and search for ready-made STL files of various shapes and sizes. You need a material. The most common is an FDM printer. So it comes in a spool like a wire, electricity wire. There is a plastic material which you feed into a nozzle. Now the nozzle has a specific thickness. Whatever STL file you have made or downloaded, already made, you put it in a memory stick and load it to a printer. Give a command of go and the printing starts. As I told you, it is additive. That means layers are being formed one top of the other. You see the nozzle is moving. So it could be either the nozzle or the platform which moves. And the image shows you how a beautiful structure is being made. It's easy. So if you start trying it with simple models or simple bony structures, once you make your first one, you will get addicted. So the things which are required are material, a software to make the plan whatever you want, and a hardware, the 3D printer, to print the model. Now in orthopedics, most of the material which we are going to use to make these models are going to be CT scans of the patient. So we are focused on improving patient care. So the data which is going to come is the patient's CT scan, and it comes as a DICOM image, which is imported into softwares. And then we play around by making a 3D form of the particular bone we want to work on. And once we've decided whatever we are doing, we are making a bone model, or we are making a tool, or we are doing a virtual surgery on the software itself to practice a technique or to understand a new technique. So 3D printing has gone through a huge transformation in the last 40 years. It started somewhere in the 1980s when Charles Hull formed the first 3D printer, and this is his picture of the 3D printer. That is a normal PC of the 1980s. And on the right side, you can see a nozzle which prints an area of 5 into 5 centimeters. So we've traveled a long distance. On the bottom, you can see a 3D printer, which is almost now a size of a microwave. The size of the printer depends upon what size of printing you want to do. There are people in this globe who are printing a house using a 3D printer. So depending upon what volume or size you want to print, the base plate would change. Most of the other components, the basic principles remain the same. So we have moved from the top picture, which used to print a paper, to the bottom picture, which is printing a stand for your mobile phone. So you're printing a 3D object. And we've already moved towards this era of bioprinting, in which people have printed in the lab various tissues, the kidney, the liver, the blood vessels. These are beautiful in vitro models at this point of time to do amazing pharmacokinetic studies in the lab. So actually they are in vitro trials, but they are using live tissue, which is absolutely same as what would be inside the human body. So this is a new sort of a dimension which is getting added to human research because of 3D printing. So what are the uses to us orthopedic surgeons? It helps in planning, it helps in research, academics and display, and doctor-patient interaction with 3D models. In surgical planning, there is no limit. It is your imagination how much you can stretch it. So you have a computer-assisted design model. You create an STL file. You use a slicing software which converts the file into various layers because the printer prints in layers. You give the command to the printer and you have a 3D object in your hand. Let's look at a small video of advanced planning. Now this is a CT scan DICOM images in which we are separating the bone which we are interested, which in this case is pelvis with both hips. You can see there is some irregularity on the right ilium. The same patient, we have used the MRI and we have marked a tumor mass which is on the outer side of the ilium. We segment it, we separate it, we make an STL file, and we transfer both the CT and MRI images to one platform. This is called fusion of images, and where we can use multiple inputs to plan out a particular complex situation. Once the fusion is done, and there are various methodologies of doing those fusions, we get a final model in our hand of the surgical patient, this being a chondrosarcoma. Then we mark out what would be the margin where you want to resect, and you create a 3D template. Now you can see a 3D template has been created, and you can easily print this 3D template, which can be used intraoperatively to guide where you are supposed to be cutting. So now you can understand that the major part of planning this case was on the computer using the CT and the MRI images. And a very minor part was printing that guiding jig, which you can see in purple on the green pelvis. So we use this intraoperatively to mark the resection margin so that we have an excellent tumor-free area, and the surgical time as well as the surgical dissection is really benefited. And in the X-ray down here, you can see the post-operative outcome in which you see how close you are to the acetabulum. So this technology really helps you in increasing the precision of your work. So you can do amazing amount of pre-operative planning in almost all spheres of orthopedics. The most common filament we use in the FDM printer is the PLA, which is a plastic. Now, we used to plan deformities using long X-rays, drawing lines, doing some tracing, getting an angle of 18.7, which is almost impossible to recreate intraoperatively. So with 3D planning, you take the CT scan, you separate the bone, you take it to the software which helps you in cutting and doing the virtual surgery. And what is the big difference? We used to plan with lines in the X-ray, and we plan with planes. We plan with a deformity plane in the 3D deformity evaluation. So once you've done that, you do a virtual osteotomy, you correct the alignment of the bone, and you have a 3-dimensional assessment of what deformity correction is required. So it is more on the medial, more posteriorly, so it is ultimately a trapezoidal deformity correction. And if it is of the range of 18.7 and in millimeters, it is a huge challenge to recreate intraoperatively. So print the wedge, use the wedge, make a hole, add a pin to the hole, use the wedge after a distractor has been applied to get the absolute anatomical correction. And then do whatever way you want to recreate the corrective deformity and get an excellent post-operative outcome. So 3D printing has been used almost in all spheres of humanity, from food to games, to fashion, to defense, to pop culture, and definitely medicine. Another example, a neglected fracture dislocation of the hip. You want to do a total hip replacement. You have various questions in your mind. What would be the problem in the anatomy? What is the fracture pattern? What is the bone loss? And how to go about it. Definitely for planning, you will do a CT. So once you have done a CT, you have the DICOM images, use them. Use them to create a model. Now we have printed a model and we understand that we can easily reconstruct the large posterior wall and almost reconstruct this as a primary total hip replacement. However, we beautifully understand that we would require a plate to fix these large fragments. So we can use this bone model itself to contour our plate, which saves time and gives you an immense amount of accuracy intraoperatively. So that's the planning going on, and in the middle you can see the post-op X-ray. Another case, if you can see the yellow mark, they are huge osteophytes. We call them elephant osteophytes, and the patient doesn't have any movement because of the huge osteophytes. We do a CT scan, we see the difference in the two femoral heads. So we use the normal head to make a template. We mirror it because we need the abnormal side to be created. We create a cup on it, attach a handle to it, so that we get the size to which the head has to be reformed by osteochondroplasty. Again, we assess the neck, we create a ring, we attach a handle, and that is how we go on the pre-op planning on the computer. And these are the two beautiful jigs which we can print and which will guide us inside the OT on how much to cut and how much to leave. So that is the 3D printed guide for the head and the neck. And we go intraoperatively, mark it, and then use various tools to recreate the anatomy which we wanted to do. We published this in 2018, and this was a very, very interesting application of 3D printing. Another interesting case, a tumor, a young girl of 16. As you can see in the yellow bold arrow in the X-ray and the CT and the MR, a large lesion which is encroaching the weight-bearing area. This is a chondroblastoma. So we used multiple applications which were available. First of all, we used the CT and the MRI to do the planning of the defect. We use the knowledge of mosaic plasty, which is used in the knee to fill the chondral defects. So we planned how many mosaics are required. We 3D printed the head. We filled it with clay. We used the same mosaic plasty tools to do our whole planning and executing the surgery in our office. We did this intraoperatively and put the osteocartilaginous mosaics in the femoral head after doing a surgical dislocation. So this surgery required knowledge of mosaic plasty, knowledge of surgical dislocation of hip, and knowledge of preoperative planning and 3D printing. So that's the beautiful post-operative X-ray, and that is now actually a 4-year follow-up, and this was published in the Japanese journal, the Journal of Orthopedic Science. You can see in the follow-up MRI how beautifully the cartilage has formed. This is the area where the plugs were put and the cartilage has been formed very beautifully. This was our first attempt where we had started our whole journey of 3D printing. We printed the human size hemipelvis of 10 acetabular fractures. We did the virtual surgery on them. We did the reduction. We contoured the plate. We fixed the plate. We removed the plate, autoclaved it, and used it intraoperatively. Believe me, even the size of the screw, the direction of the screw, and the number of the screws were so accurate that it helped immensely in decreasing the surgical time. This we have already published in the European Journal of Trauma and Emergency Surgery. So we use it very often in acetabular fractures because it's a complex fracture. We segment it, we convert the gray and black images into colorful, beautiful images. We create the 3D. We do the reduction of the fracture. We plan the plate on the normal side, mirror it to the fracture side to check for accuracy, print the templates, and bend our plate preoperatively on these templates. So you can imagine the template which is printed is a very small part of the whole exercise, and the cost is actually peanuts. Again, we published this in Archives of Orthopedics and Trauma Surgery. we, in our part of the world, get a lot of neglected trauma. Now, this is a knee fracture of the upper end of tibia. It came to us at end of 1.5 years with the problem of instability. There was a malunion. Now imagine in a 30-year-old young person, a malunion of the intra-articular fracture to reconstruct is huge planning. So we did a CT scan, we did our segmentation. We found there was a major posteromedial fragment. We separated it, we reduced it, we created a specific plate, and we could decide the surgical approach depending upon where the plate would go. So again, we printed just this template and molded our normally available plates according to this specific requirement. And that is what is a beautiful reduction in the beautiful post-operative CT, which is almost showing 100% anatomical reconstruction at the end of 1.5 years of fracture malunion. We've done some complex reconstructions. Now this is more often required in tumor scenarios where the requirements are very specific to the patient. This was a case of osteosarcoma of the talus, in which the tumor had not penetrated any of the margins of the bone. So it was amenable to resection and reconstruction with a patient-specific talus, which we again created by using the CT scan of the normal side. So the red talus we mirrored, and we first printed it in PLA. We were very sure on the size and the design and everything. And then we went ahead and printed the same in medical grade titanium. Similarly, we've done quite a few other indications like the calcaneum replacement. Using the normal side, it goes through all the phases. And then we create in this we had done a meshing to reduce the weight of the calcaneum. And you can see the post-operative X-ray. This patient is almost 2.5 years now and is doing fine. Small indications, we use 3D printing for creating molds in infected joint replacements where you need to do 2-stage revisions. Since we know the size of the implant and the make, we use the trials, we scan them, and we 3D print the mold. So you can imagine the cost of 3D printing such a mold is peanuts, and then we can autoclave it and use it for making the antibiotic spacer intraoperatively. It gives us great flexibility on what size and what shape we want to do. So we've done a few in the knees and also in the infected hips. We've been using them for guides for pedicle screws in cervical spine, which is a very narrow zone, very little error, vertebral artery on one side, spinal cord on the other side. Initially, we used to use the 3D model and practice it. Now we do it without it, and we hardly need to use the C-arm intraoperatively. So concluding my presentation, I would like to just take you probably into the future of this. We've been segmenting using CT scans and getting the bone, which is specific. We are able to create the plate. We are able to print the plate. But now moving ahead, if we use augmented reality, we don't have to print the plate. We can generate a QR code and the plate is visible in virtual thin air. You can move it around in thin air, and then you can bring your plate next to it and you can just plan your plate bending with the virtual augmented reality assisted tool. Same tool can be used, the preoperative planning and augmented reality in pedicle screw positioning, in acetabular cup positioning. And this is one of the newer avenues in which we are stepping in. Another thing which could be a possibility would be, we use so many guiding jigs for many surgeries. There could be a slight error in positioning the guiding jig intraoperatively. So augmented reality can also help you a lot in positioning of your guiding jigs intraoperatively, which you use for any surgery. So a collaboration, a fusion of various types of technologies can really help in probably moving towards an era of
personalization. We've seen a long era of mass production, but now I think we are moving more and more towards patient-specific solutions to increase the precision. And till now, probably we have used this technology for making patient-specific instruments, for making certain guides, for making certain implants, and also working and collaborating with the material experts and the engineers, and probably coming up with the bioactive and osteo-integrative materials which can be 3D printed. We already have printers which can print hydroxyapatite, but that is still in the research process. To conclude, if my friends who are interested more in reading, we've taken out this small update on medical 3D printing, which is available on Amazon. You can just search on Amazon. And we are actually moving towards this new term, which we like to call as creative orthopedics, meaning that we spend more time on preoperative planning, using all type of imaging, try to use more and more engineering technologies to create a beautiful outcome for a patient who comes to us. Thank you very much.
Dr. Lalit, can you stop sharing your screen now?
Yeah.
Okay. So see, sir, first of all, I am in shock. I am in shock. I am absolutely shocked. That's absolutely mind-blowing. You see, I have never seen something like that. I am always in the shoulder and elbow universe, and this is something absolutely fantastic. I have many questions. I just want to highlight some points to the general audience before we continue. See, sir, to be very honest, very gifted surgeon who works in many different parts of the human body, which is something that really called my attention. I realized that the most difficult the case, the higher, I would say, the indication for all of these things. These are not for ordinary cases, but we have many complex cases all around. And the word that I would say that would summarize everything, sir, is customization. Huh? You are always customizing the things for specific cases. And I am realizing that the word, and I just want you to comment that before we start, Dr. Bruno, and then we can talk a lot, is that you can use a lot of creativity. Huh? This is a sensation that I have. So you see, impossible is nothing. Impossible is nothing. You can go quite far away and you can use a lot of creativity. We can talk more about that. But there is just one thing that I would really want to ask you, sir, before we continue. That's a lovely lecture. You see, you made some bone grafting, some mosaicoplasty, in some cases in the hip. But the thing is, I would be very worried about early arthritis after all of those, I would say, of those surgeries, in a way that in spite of the beauty, you would lose the surgery quite fast because of post-traumatic or post-surgical arthritis, in a way that you would have to do an arthroplasty quite fast. So what about the longevity of such procedures in the hip, those mosaicoplasty? I'm sure we are talking about young patients. If not, you would go straight for arthroplasty. But what about the longevity of these procedures? This is a very good point, sir. What do you think about that?
So cartilage has always been a challenge.
Yeah.
Recreating cartilage is a huge challenge. And if you add age to that, meaning if it is a young patient, that becomes even a problem. And then if you add diagnosis to it, like if it is an inflammatory pathology, meaning a rheumatoid arthritis, it's a crippled patient, you know the mobility is going to be less. You still do replacements in juvenile arthritics. However,
Yeah.
if it is a pathology which is involving only one joint, like a chondroblastoma of the hip, his other systems are fine. So he's going to be running around the day you give him an arthroplasty. So the longevity of these procedures is only future can tell. However, from what we've learned from the knee joint, it is probably better than having nothing, and it will definitely give you some years. But then maybe 10 years from now, in our next webinar, I will be able to tell you the 15-year survival.
Okay, you see, sir, and the other point is that we are, in this case, is you are working on the edge. We are working on the edge. And there is just one thing that came to my mind when Dr. Ildeu organized the International Congress of Shoulder and Elbow Surgery last year. We were all there, me, Dr. Bruno, and I realized that we were all discussing the limits on that event. And this is where the difficulty comes, because you are going upon the limit of science, of what you know to what you don't know, but someone has to do it. So this is another point in which you are doing a beautiful stuff, because you see, sir, 10 years ago, you would go to plasty independently of the age. And I would say, and all of the biological options would be gone. Just one thing that I always tell my residents: when you have AVN in the shoulder, is completely different than AVN in the hip, because the shoulder is a distraction joint, and the hip is a compressive joint. In a way that I have some complex cases of AVN in the shoulder with a very strong clinical radiographical dissociation, a very ugly image with a reasonable function and much less pain. But in the hip, I think it's different. But you see, you are trying to do things, and you are trying, I would say, to do, I would say, salvage procedure. And this is something that we are discussing in the shoulder universe, which is head preserving versus head replacing procedures. So you see, the head replacing procedures in the shoulder, as Dr. Ildeu showed us, is increasing a lot, but we don't have much head preserving stuff. But you are doing this in the knee, you are doing this in the hip. And I realized that on complex trauma, you have a very serious indication for, I would say, for 3D printing. And you see, I am mesmerized, because this is a universe I don't understand. It's beautiful. And I don't know if Dr. Ildeu wants to say something before Dr. Bruno starts, because I am positively still in shock.
Yeah, thank you, Sergio. I would like to say that before dying, I had the opportunity of interview Stephen Copeland from England. And I asked him about the future of the joint procedures. And he said to me, can't be plastic against metal. Has to be biological solution. So let's think about that.
Yeah, definitely. Yes. And the only thing, I just want to make one question, and then we can start, because I am always thinking about the general public. I have many questions from the general public, but I will discuss them after Bruno's. But Dr. Lalit, as an orthopedic surgeon that we all are, what do you think about the idea that this head preserving procedures can increase the chances of infection if you do in a later moment an arthroplasty? This is another good point. Would you think that the chances of infection, if you do a plasty after all of these complex biological procedures, would be quite increased? Do you have any concerns about it?
Theoretically, you might say yes. You would have papers to support your evidence on this thought. However, probably the concept is being sold by the arthroplasty enthusiasts, because there is less evidence on the longevity of the salvage procedures. Like the amnioplasty procedures and the various newer technologies which are coming on reconstructing cartilage still have some time to tell us what's going to happen. But then this apprehension that probably doing a primary arthroplasty is always more safer is valid, but then it needs to be weighed against the time and the other downsides of it.
Yeah, the only thing is that I just want to mention one thing, because this is something very serious about your, allow me to use the word courage, okay? When I was in 2010 in International Congress of Shoulder and Elbow Surgery, Stephen Burkhardt, he said, it's very difficult to work in the edge, but someone has to do it. Because if no one does it, we are going to stay all of the time in the same level. So this was about some points in arthroplasty 10 years ago, and see where we are now with all of the beautiful things that Dr. Ildeu has said. So someone has to do it, and I'm very happy that we have people with your guts, allow me to say, to be pushing the limits. You are pushing the limits, sir. And this is very important, okay? This is how science goes with difficulties, but in spite of all of the difficulties, this is how science goes beyond and beyond. I'm quite sure that Dr. Ildeu agrees with me and Dr. Bruno too. So Bruno, can you start, if possible, you talk a little bit about shoulder, but we are very excited for your lecture, and then we can start discussing.
Thank you, Sergio. I will try keeping my presentation widely on orthopedic. So my name is Bruno Gobbato. I speak directly from Brazil, from the south part of Brazil. First off, to be here with you guys from Shoulderplanet Ortho TV, Dr. Lalit, a wonderful presentation. Ildeu is a close friend, and I was hoping to see his presentation because it has lots of information for me as shoulder surgeon, but also as a creative orthopedic surgeon, just like Dr. Lalit. Biomechanics is very important. As I said, I'm a shoulder and elbow specialist. I work with 3D printing for some years. These are some of my 3D printers that I have just here in my home office. And I have no disclosure for this presentation. All the printers, the software were bought just directly from me, of course, with my wife's agreement. Not always, but some of the times with my wife's agreement. And the objectives of this presentation is to show you from all around the world how 3D planning techniques can be done for non-arthroplasty surgeries, like reverse total shoulder arthroplasty, can be done in fractures, in osteotomy, in your day-by-day cases. And how can this be done with no special or company-related, very expensive software in a very homemade way? And how even you can design your own patient-specific guides, your own patient jigs, just as Dr. Lalit just showed us for his wonderful and very, very difficult cases. I'm going to show cases that are not as difficult as his. I'm blessed. I don't have this kind of cases just like Dr. Lalit. And one thing that's important is that 3D printing, of course, is not for all surgeries. If you have to do 20 surgeries a day, we won't be able to do for all surgeries, but for some it's needed. And we live in Brazil. 80% of our population is from public health. We have no good implants. We have no locked plates for most of our patients in Brazil. We don't have actually reverse total shoulder arthroplasty for 80% of our population. So we have to work with old implants. So we have to be very creative, but that does not mean we cannot have cutting edge technology to do this for our patients. The steps for this presentation are going to see. expect 10 to 20 minutes of examples, how 3D printing, 3D planning. And then I'm going to end my presentation and show you a very quick but live planning, how we can do quickly and easily directly from your computer, and everyone could do that. We started our 3D printing thinking that 3D printing could be to select the implant, just like Dr. Lalit said. So I started from my clavicle fractures, choosing priorly to the surgery which implant I was going to use, and I was satisfied with that. Then I was started using the 3D printing during surgery to help me understand the anatomy and maybe doing less invasive surgeries, something like that. But then we try to understand the 3D printing way, and we started to really 3D planning our surgeries to avoid using the 3D printing as just a tool for selecting the implant. And this is one example that allows us to do minimally invasive cases with less or even no fluoroscopy. I'm going to show. This is an example, a clavicle fracture that we have 3D print. This is the same clavicle that we have 3D print with the screw holes from that implant. And that will help me even more because I know exactly where each screw should be in the patient. And then we design patient-specific guides, patient-specific jigs to direct the location of the screw. And I'm going to show why we do that when we have the proximal humeral case. So here is an example. The video is running the medial part of the clavicle. This is the left clavicle. This is the 3D printing. And this is the guide that will show me the direction for the first screw. And here we have the lateral part on the right side of your views with the guide for the distal part of the clavicle. And why we do that? Well, I'm going to just hold a little bit. I'm going to show why we do that. This is an example for proximal humeral fracture. It's a very common fracture, but it's all that has already done. We know that that's not very easy. The anatomy for the cuff that doesn't allow us to understand exactly how the head is. And we started doing 3D planning for proximal humeral fractures. This is an old patient that has a posterior dislocation, a 3-part posterior dislocation fracture. And we were not very sure what we're going to do. We're going to do a arthroplasty. We're going to fix. So we don't have a reverse. Let's fix. Let's do an old and partial, shoulder arthroplasty. So we choose to reduce in our computer, first to understand if we could have space because the head was somehow affected. And this is the reduction for the surgery. We were okay, principally because we thought that we have space on the head. The head was not that compromised. And we have planned the surgery. This is, in this case, using a locked plate for the proximal humeral part. And here we have the 3D printing that would help us, in this case, in the same case, selecting which implant. But in this case, who is shoulder surgeon know that for this case, the most important knowledge is to understand, the height of the implant, because this is very difficult to identify during surgery. So in this case, the 3D printing could help us in a very simple way. In this case, we do the 3D printing and we do the guides for having a perfect location for the implant because the head was somehow small because of the deformation. This is how we plan, and this is how we achieve the CT scan one year after the planning and doing this kind of surgery. And why we are doing that? Because we are creating our own patient-specific guides actually for almost all our surgeries, even for proximal humeral fracture. This is a simple fracture. And why we are doing that? Now I'm going to answer you guys. Because when we plan our surgeries in advance in our computer, as you are seeing here, we can change the paradigm, for we reduce a fracture and then we fix with the implant. And when we plan, we use the implant to automatically reduce a fracture without using any special, for example, no fluoroscopy. So when we plan the surgery, when we have guides, the fracture or the osteotomy is automatically reduced. I'm going to show how. This is the proximal part of the humerus. We design a guide that shows us the location for the 2 proximal screws. So we adapt the guide, we drill before the fracture is reduced. We drill 1 screw or 2 screws. Then we adapt the guide to the distal part of the humerus, and this can be done with any fracture, or this can be done with any osteotomy or deformity. We drill, again, the two screws holes. Now we have the fracture with the pre-drilled screws. Now we just need to adapt the implant to the holes, and the fracture will automatically reduce, as we see here, without using sometimes, or most of the times, any using of fluoroscopy. We just need to adapt the implant to the pre-drilled holes. And this is very important for osteotomy. This is an example where we are showing the 3D printing, and that allows us doing minimally invasive cases because we know exactly where the implant will be in all the steps of our surgery. This is a video I'm going to pass forward because we have no time, but this is an example of the proximal guide. Of course, we are now using different types of guide, but we are drilling the proximal part of the humerus. I'm going to pass forward. Now I'm drilling the distal part of the humerus. The fracture is already reduced. It's still not reduced. It's just as it is. Now I'm going just to adapt the implant to the pre-drilled screws from the distal part. And then I'm going to do some maneuvers to match my implant to the pre-drilled holes, and the fracture is automatically reduced. And we do the fluoroscopy only to check if everything is okay. And now we just need to do the rest of the screws. So this is another example of how we can do. We can do for something, we can use a guide as a sternal fixator, just like that. So we can do. We can plan different parts or different surgeries. We can use a guide like that to reduce a fracture, for example, and then you can use whatever implant you want, even K-wires you can do with this kind of technique. This is some examples that we use in our days. We use everything, 3D printing. We use augmented reality. I'm going to show in the next slides. So we can do this in a very do-it-yourself way. It's not that hard to do everything, but everything starts with planning the surgery in your computer. And then you can have a augmented reality, you can have 3D printing. But first, you guys have to understand and have to have some time to plan your surgeries. And the advantage are lots. Dr. Lalit has already said, but we are actually reducing the steps during surgery, but increasing the steps before surgery, of course. All these steps is what we need. I'm going to show very quickly in a 5-minute live presentation. I'm going just to show another examples very quickly that how we can do. This is a planning for a Latarjet procedure. We use the 3D printing to direct the location for the screws, but we can create our own instruments. That's wonderful. This is a hook. I forgot the name in English, but this is a 3D printed instrument for holding the coracoid and drilling. So we can be creative, just as Dr. Lalit, and create our own instruments for our own surgeries. This is another example of an instrument that we have drawn in Windows software called 3D Builder, which is the software that your kids maybe will play with, and we can do 3D printing and create our own patient-specific guides and specific instruments, specific retractors, specific guides for any surgery that you want. We know arthroplasty, in this case is for shoulder arthroplasty, is where the money is for shoulder surgery. So is where the implants company want us to use 3D printing, 3D planning, and of course, we need to do in bad cases. There are softwares just like that from Blueprint. This is a planning software, but for that, you need to use the right hernia implant. So we are showing you guys that we can do this exactly like our fellows in France, our fellows in the United States. We can do this in our home in a very do-it-yourself way. These are examples of the guides for the planning that we do. This is a glenoid, the example of a 3D guide that we can design for our surgeons, and we can be creative doing whatever design that we want. This is another example. This is an example of augmented reality of a planning of a shoulder arthroplasty. You can see that this can be done in a very easy way. You saw my wife going back. So this is not difficult. I'm going to show you in the next few minutes. We can plan graft. This is an example like 3D, where 3D printing and planning is very important to understand exactly, for example, the correction that you want to do. So this is the software, the planning, and the graft, in this case, for a reverse total shoulder arthroplasty. This is what we print in our daily basis. We plan the graft, we plan the correction. Some examples of augmented reality. This is free. This is a free app. Everyone can do in your home. You just need to print this paper and point your computer. Point your smartphone. I'm going to show. And one thing that's very important for osteotomy, Dr. Lalit showed us an example of proximal knee osteotomy. I think for corrective deformity, planning is mandatory. I feel I'm negligent when I do not plan or I do not 3D plan a corrective osteotomy. So 3D printing can help us do this case. I'm not going to show knee and hip because Dr. Ali wonderful showed his case, and I'm embarrassed showing my cases. His expertise is so huge that I'm going to step forward this part of presentation. So I'm going to go very quick to the end of the presentation. I'm going to skip this part because Dr. Lalit wonderful done that. Sorry about that. This is a guide that we have done for correction of a case, just like Dr. Lalit said. This is how we done. And I'm going to show about augmented reality very, very quickly. This is an example that we are using augmented reality in our surgery. We're using a glass. This is a fracture, a left clavicle fracture. We can place our planning in space, as you can see, the lateral part of the clavicle. This is the planning. We plan all our surgeries. We don't do augmented reality for all surgeries, but we plan all our surgeries. Here we have the 3D printing, the medial part that we plan, the lateral part that we plan, the direction of all the screws, because that will help me understand exactly how the implant will be on the OR. You can see, just as Dr. Lalit showed, we can use the planning augmented reality to check if the implant is in the correct position. We can place our hologram. This is in 3D, whatever we want, as you can see. And then we can use it during surgery to check if everything was done just exactly as we have planned it. This, of course, it's a cutting edge technology, but we can do it easily with your smartphone, and you can do it right now if you want. You just need a smartphone and a cube just like that, and that can be printed. I just printed today this cube. It's a paper that I have folded and glued to form a cube. Okay, so using a free app, it's called Object Viewer. It's for iOS and iPhone. Object Viewer you can download. And if you code these codes that I'm showing here are some examples of some of my patients in 3D that you can do. So you can take a screen from this presentation and test these codes. I'm going to show you live in 1 minute. So I'm going to exit my presentation, but I'm not done yet. Sorry, Sergio. I'm going to show 2 very quick ways that we can do first augmented reality. So
Bruno.
Sorry?
Bruno, just one thing. It's so nice, your presentation. If you want to take more 10, I am controlling time. If you want to take more 10 minutes, it's okay. And then we will have at least 35 minutes, 40 for discussions, okay?
I speak very quickly. Sorry, Sergio.
No, Bruno, yes, please. We are enjoying it. Please, please don't hurry.
Yes.
We are liking it.
Yes. Bruno, I am enjoying so much. And Dr. Lalit too. So don't hurry. You have, even if you want more, 15, because it's mind-blowing. And Dr. Lalit also wants to see you, okay?
Perfect. I'm
okay,
going just to show that. I'm sharing you my iPhone screen. This is my son. I'm going to open the app. It's Object Viewer. Okay. I'm going to open here. Oh, let me exit just a little bit. So if you choose to click on research for code, you can place one of these codes. Let's do it together. JTDP. Well, these are patients that I have uploaded for this system. Okay, it allows 5 uploads freely, and you just need to print this cube. Okay, and now you just need to point the cube, and you have this is a patient. This is come from the CT scan. It's a young patient fit that we can use augmented reality to check, for example, all this pay. And we can do this, for example, for our planning, but this is very easily done. I'm going to show you how we can do this in the next 5 minutes. So this is done freely. We have no cost to do that. And you can use 3D print. I have lost my cube, so I just printed today. How easily this is done. I'm not very good in crafts, as you can see, but we can work very easily. And you can have this in your OR, or you can use to understand for teaching your students, for teaching your fellows, for teaching. I'm using this in med school to teach anatomy. And how to have your own models. That's I'm going to show you live also right now. I'm going to close my computer. Dr. Lalit also showed us his steps, and my steps are just the same. I'm going just to show this live, how we can be done. I'm going to use a software called Indo-Brazilian. It's a Brazilian software, but there is in English, many languages, and it's free, of course. So I'm going to use that software called Indo-Brazilian. It's very simple to use. It has 4 steps. Sorry, it's in Portuguese, but you have English, but it's very simple to follow. We have step 1, 2, 3, and 4. So let's start with step number 1. We are going to choose our CT scan, the DICOM files. The DICOM files you can find on the CD of the CT scan or from the radiology. Okay, the DICOM files are the files that has the raw image. So people from radiology understand that. We just need the DICOM files from any CT scan. It does not need to be a 3D, cutting edge 3D scan. Any CT scan around the world, we can do a 3D model. Of course, if the CT has more cuts, more resolution, it's better, but any CT scan can be done. We just need to import the DICOM files. Here we have, it's a clavicle, okay? We have all the images from the CT scan, as you can see here. We are going to choose the axial view. We all know how to use this kind. I'm going to click, so I choose the axial view. I'm going to click on import. Okay, Now it's importing the axial view. And now we are on step number 2. And what is step number 2? To choose what the tissue we want to create in 3D. The software already knows that we are orthopedic surgeons. I'm kidding. So he has already highlighted in green the bone tissue, as you can see here. Okay? But in this threshold, in this slider I'm going to show here in green, we slide it to paint in green the tissue that we want. This is not good. This is too much. We only want the bone. So I'm going to paint in green the bone tissue. I think we are okay. And now I'm going to click on Create Surface. And it will take 1 minute at least. And what the software is doing, the software is having all the axial views and merging together to create a 3D view directly from the axial view. And now it's done. Here we have the 3D view. We can work around, we can zoom in, zoom out, and it's done. Okay. Now we're going to pass to step number 4. Step number 3 is not needed. To export surface 3D. Let's save on our desktop. Well, let's call clavicle fracture webinar. It's for today. Okay, now it's done. These steps, very easy. I'm going to close this app. I don't need anymore this app. Okay, no, so just save, cancel. Now that file I'm going to open right here. Let's find our desktop. Clavicle fracture webinar. Here is the file. So if we want to 3D print, we can do it right now, but we don't want to 3D print everything. We just want to 3D print the clavicle. Or if we're going to do a planning, we just need to do with the clavicle. So we're going now to do some cleaning, as well as you go to when you have a picture on a wedding, the photographer always do some tweaks to make you feel like good looking. And that's what we're going to do. We're going to open this file in a software also free for Mac, Windows. I'm going to show only things that are available for Mac and Windows. I'm in my Mac, but Windows is just the same. The software is called Mesh Mixer. It's free. It's from Autodesk. You can download it free, very easily. I'm going to import that file that we have just done. Okay, clavicle fracture webinar. Open. It will open the file, the 3D file that we have just done. We don't need more the CT scan. We already has the 3D model. Okay, just a second. It's a big model. We're going to reduce it right now. So we have here everything. We have the scapula, we have the clavicle, we have everything. In this case, we're going to work only with the clavicle, okay? So I'm going to hit select, okay? And double click on the clavicle, 1, 2. Okay, again on the lateral part of the clavicle, 1, 2, perfect. Now I'm going to separate. Okay, I'm going to separate the clavicle from all the rest. The rest doesn't matter to me. So I'm going to just hit here the Y key or separate. Perfect. Now I have everything else and the clavicle. Okay, I'm going to delete. Just hit here on the garbage can. And now I have the clavicle to work on it. If I want to plan the surgery, for example, reduce, I'm going to do that. I need to separate again the lateral from the medial part. So double click again, edit, separate. And now I have lateral and medial part. So let's plan, let's do the planning. I'm going to select the medial part, edit, transform. And now let's move it in space in order to reduce the fracture exactly how we want. Okay, like that. I'm not going to do a perfect reduction. We can rotate, we can choose rotating, we can do everything that we want. But for this webinar, I'm going to show very simple cases. And that's it. that is the reduction. Let's assume it's okay. If I want to plan the surgery using an implant, I can import an implant. For that, we need to have our implants draw. We need to have the 3D file from the implant. In this case, I do have. Of course, you won't be able to have on your computer that, but planning the surgery you will have. This is the implant that we have brought from the CT scan, and I can plan the surgery just as well as I have done with the medial part of the clavicle. You have to work on 3D, so it's for us that are surgeons, it's sometimes difficult to understand the 3D part. I'm going to do it very, very quickly. Just change something like that. And it's not okay yet. I'm sure Sergio would done very better than me. He's a very meticulous surgeon. So, but I'm going to accept this reduction for this fracture. And then we have printed, we have done, we can export this to take image. And now we can even export this to our augmented reality. We just need to export the file, export in STL, clavicle. Let's zoom that, desktop. And now we just need, for example, we can open in our phone because we have apps that can open STL file in our phone. We can do augmented reality right now. Just need to upload to that platform and use it as well. So it's not that hard. Of course, takes some time. We need to have some implants. I'm going to show very easily how to do a osteotomy. Very easily how to do it. I'm going to combine this. So now this is a clavicle. Imagine that this is a non-union. This is a clavicle that has a misdisplacement. Okay, let's imagine that it's not a fracture. It's a non-union. We can just do exactly what we done. We choose edit and plane cut. Plane cut will cut the model in a plane. So we just need to choose where do we want to do our osteotomy. We want to do that way. We want to do that way. We can rotate wherever we want. So let's assume that we want to do a that way osteotomy. I can hit accept. And now I have a osteotomy done. I have the lateral and the distal part. I just, if I want to plan a enlargement of a clavicle to merge if everything is in the correct position, I can do whatever I want. If this is a knee, if this is a hip, I can plan my osteotomy. I can correct everything that I want in some simple steps. Sergio, that's what I was planning to show you. Of course, this was very quick. I'm not assuming that everyone will do this like that, but my intentions were to show that you can do it in your home. You can do it in your own computer. We don't need any, you need a special software, but no expensive software because this is free. And you can be creative. You can try doing that in simple cases, just like fractures and something like that.
Bruno, can you stop sharing the screen?
Of course, my friend.
So I would ask Dr. Lalit and Dr. Ildeu to open the cameras. Oh, now we, you see, now this is like Tom Cruise in Mission Impossible. Fantastic. So let me say something. I am really, I would say, positively shocked. I was thinking about Steve Jobs. He used it to say whenever, Steve Jobs, he used it to say, whenever you have something very new, you become quite shocked and impressed. This is how I am now. There are many things passing through my mind. This is mind-blowing, but I have, I'm gonna say one thing, and then I have basic questions, but obviously Dr. Ildeu can say a lot of things too. And I want Dr. Lalit and Dr. Bruno to answer that. The first thing that comes to my mind is this. I learned it, this is a serious point. I learned it in the United States that you cannot fix what you cannot see, and that seeing is achieving. So I do a lot of complex fractures, my friends know, and I do big openings, and I learned to do to see the normal anatomy proximal to the focus, the distal normal anatomy, and then go to the altered stuff, the altered anatomy, okay? And that in that point, I do, whenever needed, big incisions, and seeing is achieving, and you cannot fix what you cannot see. I learned that in San Diego shoulder a lot of times, and these are very key points in my practice. And then you come to me and you make me understand that we can go minimally invasive. So this is maybe a breakage of a paradigm, at least in my mind, and changing some concepts that I have been using for 15 years. So am I right about this, in a way that when you do all of this planning, you don't have to do such big incisions, you have to see less things intraoperatively because you are seeing more things preoperatively? Am I right, or is not exactly like that? Dr. Lalit, what do you think? And Bruno?
You are right. You are right. All these technologies also have a learning curve, meaning you will reach to the level of Bruno after spending few years. So it will not happen in your second surgery. And the concept of viewing, I think when you use these technologies, you are viewing even more. Like there was a thought that why do arthroscopy when you can open and see everything? But with time we have realized the corners which we can see by arthroscopy, you cannot see at open also.
Sure.
So similarly, in virtual planning using CT and MRI, you spend time with these CTs and MRIs. I can tell Bruno would be spending time with these CTs more than when this technology was not available. In those times, you would just have a glance on the CT, you would see the reporting by the radiologist and move ahead. But when you do this planning pre-operatively, you are fascinated, you enjoy it. So you even look deeper and you look at minor details which you would have missed other time. So I would see you're seeing even more, but you are even more well prepared by the problems which would come, and you have already probably created solutions before entering the battlefield.
Yeah.
So Bruno, your thoughts?
I totally agree. When we do a proximal humeral fracture, for example, sorry for that. We think that we see everything, but we don't. We have the cuff. So our field of view for the fracture is something like that. That's what we see on a fracture. We think that we see in 3D, but actually what we are seeing in 2D, because this is the field of view. We don't see this. We don't see this. We see this. So we imagine when we see this, we imagine in our head how this is in space, because this is what we see. And one thing that changed for me, Dr. Lalit was very his words was very correct, very happy in his words, is that I changed my way how I plan things in my head, because most of the time I just replicate what I have learned with my teachers. So I have learned that proximal humeral fracture, in this case, I do that. So I'm not thinking why I'm doing that. I'm just replicating because I have done 20, 15 surgeries with Sergio. Sergio always do that. So I'm going to the surgery, I'm going to do exactly like Sergio, but I'm not thinking. And when we go to the computer, when we do the reduction, well, I'm going to rotate this way with you. Oh, okay. That's why Sergio done that, because he's rotating that way. He's adjusting the varus, he's adjusting the rotation. And you can understand why you, as my teacher, done that because I was just replicating my OR.
Okay, just one thing before Dr. Ildeu speaks, because now I'm coming finally to something I have a lot of experience with, at least. The thing is, I have a lot of experience with complex proximal humerus fractures, but you were right about we're not seeing with our eyes, but there is something we are taught, and I am very experienced in that, is to have the help of the C-arm, the image intensifier. Okay, this is very important. But in this sense, would I be correct in saying that with this technique, you don't have to count so much, to rely so much on the C-arm view?
Yes, I think that is a very, very important message. As I had given an example of the pedicle screws in the cervical spine. That's a very, very tricky surgery. And we were not doing that surgery in our institute. But when we got the jigs available made for them, it became a possibility, meaning we wanted to do it only if we had navigation. But when we got the cheap substitute of navigation, the guiding jigs, we have started doing it. And our C-arm shots have drastically decreased. First and then the final shot with all the screws. So it makes a huge difference. And another point I would make for the shoulder surgeons, you have an anatomical neck humerus fracture with maybe a GT fragment also. So you look at the scan, it's a 3-fragment fracture and you go ahead. But when Bruno looks at it, he creates a 3D reconstruction. He suddenly realizes that the head is severely internally rotated. Meaning that there is only one muscle end which is attached to it, and he's getting guided upon what is to be derotated, whether he wants to derotate the head or the arm fragment to get the reduction. So the rotation of the fragments you start looking at, you start planning the reduction maneuver in your office. Okay. I'm not shoulder surgeon. Sorry for mistakes.
No, you're right, sir. The thing I just want to mention, and then Dr. Ildeu has something serious to say. The thing is, we are taught, and I teach this to my residents, that we have to do multiple C-arm views intraoperatively. It's not only the AP view, it's the axillary view, and maybe with some internal rotation, some external rotation, not only to see the reduction, but to see that you don't have articular penetration of the screws. This is very serious, okay? But you see, but I do everything intraoperatively, especially with the C-arm, and you see, I'm very experienced in this. But what you were saying is mind-blowing, and you're changing the paradigm because you start to reduce the fracture in your house, okay? Much more preoperatively. But Dr. Ildeu wants to say something nice, please.
Well, both were very stimulating presentations. And I would suggest you, Bruno, to make a course, do it yourself. That's the name of the course, okay? Yeah. But I would like to ask 2 questions, because sometimes when you use these guides for the glenoid defects, the position of the guide seems to be very strange. And I think, wow, I was doing everything wrong in the past. So how can you explain these different positions that without 3D reconstruction, we would never put the guide like that? The second question is about the pitfalls. So it seems that everything works perfectly. So it's like, you know, you do the 3D and perfectly it matches with the bone.
Like a puzzle, like a puzzle.
Yes, like a puzzle. So sometimes you have bone defects. So what kind of pitfalls you both had during the procedures using 3D reconstruction?
I'm going to not every time works fine as we plan, of course. Sometimes we plan a guide that will fit perfectly, but then we forgot that we have the deltoid around it. Then we forget that we have the cuff. Of course, things that are shown in a webinar are the beautiful cases, as everyone. And that does not mean that every surgery, the guides fits like that, and we do everything in 10 minutes, it's done. That's not sure. But even on that cases that the planning, I have trouble, it was easier because I know, I have in my mind, when the 3D printing doesn't work or it's melted on the autoclave or the guide breaks, doesn't matter. I have in my mind, answering your second question, where the screw should be, the position of the screw, and that avoids us, Sergio, to do interarticular screw because I already know where it should be. I don't need to check. And answering your first question, then I give my words to Dr. Lalit. We don't know for sure, for example, for shoulder, if we done wrong in the past and now this is the correct way. We don't know if now we are placing the glenoid in the anatomical position and we don't know for sure if that is the best way. But I can say that we did not know in the past. We did not know what we are doing. We are just looking in the glenoid and putting the implant in that position. Now, at least we know if we are doing on the anatomical position or we are doing in the position that we want to do. So I don't have the numbers to say we are doing better, but for sure, at least we know what we are doing because we did not know exactly for sure. So something like that. Sorry, my words were somehow...
No. See, you are right. Because I don't want to feel, I'm just gonna make a joke. I just don't want to feel that I have been doing wrong all of my life. So so just after the presentation, I'm going to the drugstore to buy antidepressants. Because I would realize I've been doing wrong things all of my life. I'm not defending myself. What I think is that with this technique, we can do better. Because we have always been thinking about, and I know a lot about proximal humors, of course. So we have thinking about, rather than anatomical position, we are thinking about the head-shaft relation, the cephalic diaphysial angle, and proper position of greater tuberosity. And maybe with these devices, we can go further than that. Will that change the final clinical outcomes? Maybe it's too soon for us to know, but much probably yes, because see, when we do a proximal humerus, you don't see the whole humeral head, and you are completely right, but what you have said is important, because even if something doesn't work nicely intraoperatively, you have already done the understanding in your mind. So it's not everything intraoperatively with the concepts. And this comes to what Dr. Lali has said. Customization, yeah? But especially talking about costs, everybody wants to know two things. What is the material that you guys use, and what about the costs of the printer? This is something that everybody wants to know.
So should I take that?
Yes, sure, sir.
So I think the biggest investment is the brain of the surgeon in between the earphones.
Yeah.
The time for the surgeon as well, Dr. Lalit.
Yes. So the first step is to understand and realize this technology is helping you. It is going to help you. Next step is you will have to invest time and readability to learn this technology. And then comes the cost. I think the cost is peanuts. If you want to ask me the cost of a printer, which I have, it is around $500 US, around 50,000 rupees. And the cost of a spool, which is around 1 kg of a wire, 1 kilogram, you can make easily 10 models out of it. It's around $20. around 2,000 rupees. So the cost is not the inhibition now. In the last 5 years, the cost has crashed.
Okay.
So the cost is in the mind if you really have to apply yourself to learn it. I think Sergio must have presented his initial presentation in the cardboard slides with a cardboard projector. And then you move to the PowerPoint. In the initial phase, we didn't want to move, but then we gradually learned it ourselves because it was so good. There was so much flexibility, so much you could do in the PowerPoint. So we did by learning. Same Bruno has done. He has learned by doing and getting involved in more and more cases, learning about free software, using them, using help tools, and then finally getting to it. So definitely there is a learning curve to it. And one thing I want to add is that you as a person, as a surgeon, has to be involved in the planning. Otherwise, there could be a crazy thing which can happen that the fellow has planned a jig for glenoid pulling and he has taken a reference around 2 inches on the posterior side and your approach is anterior. So your anatomical understanding of the exposure has to be there when you're planning the whole thing. The thing which is printed is a very small thing at the end of the day, but a lot of thought process goes into how to place it, where to place it, is it right or is it wrong? And all these materials are actually plastics. They are bioidentical, biocompatible plastics. They can be easily autoclaved in the normal steam autoclaves, which we use in our operating theaters. Now, will they get deformed or will they break? Now, if it is made in a very delicate way, meaning that anything which can break by handling by a surgeon in his hand will definitely break while you're autoclaving, because while keeping anything on top of it, it will break. So this again has a learning curve. You will yourself understand that what is a thickness which doesn't get deformed. Mm-hmm. So with time you will understand, and if you create an unbreakable thing, that will never become breakable due to autoclaving. So it normally doesn't change a shape or doesn't break.
Okay, Bruno, your thoughts quite fastly, because there are other questions about costs and difficulties to autoclave.
Perfect. The printers, there are so many companies. I suggest buying the Chinese printers that are very good and very low cost. I have here 2 Chinese printers. Today they cost $250. Okay, for the printer. Is 1/2 of iPhone 12 that is already just released. It's 1/2 now, 1/4 of iPhone 12. One quarter of iPhone 12, not iPhone 12 Pro, the iPhone 12, and and the spool, the plastics is very cheap. I say that the coffee that I take on my lunchbox, on the cafeteria, it costs high money than the 3D print that I have just used in my surgery. So if after the surgery I go to have a coffee, it will cost more money to me than the 3D printed model and the 3D printed guide. I choose not to have coffee and have the 3D printing guide.
I know, but the thing is, what Dr. Lalit, there is a message that costs is not the problem. This is something that I was very afraid about the costs. Before moving on, Bruno, your difficulties with autoclaving.
I have more difficulties than Dr. Lalit. I have some tweaks. It's a plastic, so you think it's just like a chocolate bar. So if you put your chocolate bar on your hot car, and if you do not touch it, it will remain that way. But if you touch, it will melt, okay? So you have to be very careful, just like a chocolate bar on your pocket or a chocolate bar on your car. So there you can put materials together. They do not touch. You can't have metal touching it. So you have to have some tweaks, some steps. I choose to put in a the material inside a open box, because the plastic from the stem they tends to collapse just like that. So it's something like having the Ruffles pack of potatoes. They do a very big sack. So you have to be a very big sack because it should not touch your model. That's my tips for autoclaving.
Okay, and now I want to, before moving, because I want to talk about biomaterials. Ildeu, do you have so far any questions about costs and about autoclaving? But I really would like to talk after that, especially about arthroplasty, where Dr. Ildeu understands a lot, and I want the help of everybody about biomaterials just after the question of Dr. Ildeu.
Yeah, I have a question regarding the spacer and using antibiotics in these spacers for infection. So using the autoclave, does it change the quality of the antibiotics? And how do you put the antibiotics in the 3D printer?
Good question.
So we actually 3D print the mold. We preoperatively scan whatever implant was used. We use the trial of that implant and scan it. And then using that scan image, we do a reverse engineering and create a mold. That means we create structure outside that scanned area, as I showed in my image, and we 3D print that. And then intraoperatively, we use the Palacos, which has antibiotic. We pour it into the mold, and we allow the cement to set in. Once the cement has set in, we create the molds in such a way that we can bivalve them. So once they have set, we just bivalve the mold and throw away the mold, and we have the set cement in a desired shape.
Okay, but Cesar, I would really like to comment upon, and I'm sorry, but my mind automatically comes to the shoulder. I'm sorry. This is how I think, and Dr. Ildeu too. The thing is, I just would like Dr. Lalit to help us understanding when you are doing augmentation on reverse to fill B2 defects. Would it be mandatorily metal piece or some biocomposite to do some osteo integration? And having said that, sir, what about tissues, I would say, or materials that could be used as biological tissues to be, I would say, integrated by the human body in a definitive way, like I would say grafts, so that would be accepted by the human body. I think that this is the future. I guess that you have more experience about that than Bruno, because you do a lot of tumors, sir. Yeah, yeah. So I was thinking Bruno doesn't know too much. So you are the only guy who can give us an idea, sir, about biocomposites that can be used to be definitely in the human body. What do you think about that, sir? I know it's not an easy question, but you are the guy.
So bone defects are a challenge, and that seem to be a major issue in longevity of the glenoid prosthesis. And if you can take ahead the knowledge from the knees and the shoulder and the hips, which have now lived for some time. Now, if you see the knee, for a small defect, they would use just a cement augment, and for a larger defect, they would go for metal wedges. For very small defects, they would still do a bone graft, autogenous bone from the cuts itself, but then augment it with a longer stem in the tibia. But this longer stem is not possible on the glenoid side. You have that limitation of around 2 centimeters. Sure. You can't go beyond. So that means you need a more stable structure, which needs to integrate with time. So probably at this point of time, the knowledge would say that customized wedges is the solution. However, if you go by the knowledge in defects in the acetabulum side, trabecular metal has been a major solution to various problems. And now in the acetabular side, we get customized trabecular cups which incorporate the defects, and then they have a promise of strength to begin with and bone integration as time passes. But as Sergio mentioned in the beginning, that shoulder is slightly different, that it is not compressive. So I don't know, because by Wolff law, to bone to form, you need stresses going along it. Definitely, even shoulder movement, you have stresses, but how much, we don't know. Probably that's the gray area.
Yeah, because see, sir, and I would like Dr. Ildeu to comment upon it. I don't have experience, thanks God, of putting big, I would say, big pieces from bony banks in arthroplasty. But when you see the French, and they do it a lot, very difficult cases, what I've been seeing, and Dr. Ildeu, I want to know his thoughts because he knows much more than me and Bruno for sure. You see a lot of reabsorption of these bony pieces from bony banks over years. And then when you see the X-ray after 3-4 years, maybe 2, you say, Jesus Christ, it disappeared. So this is a problem, okay? And maybe with this biocomposites, well, we can solve it in the future. I know it's a difficult issue, but Dr. Ildeu, feel free to answer. And I know that you've been in the UK and I have a lot of experience on that, about reabsorption of bony, of human grafts, allografts from bony banks. It's beautiful when you put it after surgery, but after some years, it's desperate, at least radiographically, very difficult to deal with that. What do you think about that?
Yeah, thanks. When you use big grafts, more than 1 to 2 centimeters square, in the middle of it, you are going to have a necrosis because the cells are not supposed to live without having oxygen, glucose. So in this case, we had done a lot of revision cases in UK with Professor Angus Wallace. And in that case is that he put a lot of grafts in the past. We opened and it was not incorporated. So it was there, dead, simply dead and without structure. So the incidence of complication of these big grafts, they're very high in my opinion. So I would go for these customized glenoids, putting some bone ingrowth on that, some porosity for the bone to grow inside of it. So that's something that we really don't know when the future will tell us, but at the moment is my opinion.
Yeah, and you see, I don't want to open the box of Pandora, but as we are discussing so difficult issues, Dr. Lalit, about these biological things like PRP in this biocomposites, do you think that this is just a dream, or you have something about it? Because orthopedics is going on biology more and more and more. So what do you think about that, sir? Do you have any clue? If you have nothing, that's absolutely acceptable. But what do you think about that? To increase osteointegration and to decrease, in theory, the chances of tissue reabsorption?
I think allografts came in a big way, giving the philosophy of structural reconstruction. But then there were no osteogenic cells, and there were no stimulator, the enzymes, the BMPs in them. So it was just a scaffold. So that is where gradually we understood that they are going to lyse unless the circumferential vascularity takes up very fast. But if that doesn't happen, they are going to lyse. So now they are no more taken as structural grafts. And about PRP, PRP has been here for 2 decades now, and it has changed its concentration, its centrifugation speed, its cell count, its volume. but I don't think it's still giving an answer. Probably a bone marrow aspirate and the concentrate from a bone marrow aspirate still is giving better sort of results, and probably the philosophy is closer, and probably bioengineering.
You see, coming to general orthopedics, just a comment, and then Dr. Ildeu wants to speak. As Bruno said, there are a lot of pressures from the industry in some aspects in shoulder arthroplasty, but there is a lot of pressure, at least in Brazil, about grafts. You have this one, and you have liquid ones, and you a lot of pressure from the industry because they are very expensive. But I used to make
synthetic grafts, yes, Sergio?
Yes. But what and these grafts, they are going much beyond that, only small pieces of hydroxyapatite. But the thing is, I always say to my residents, there is nothing better than graft from the own patient. Okay, it's not only the cheapest, but it's the best. So nothing can be as good as your own biology, at least so far. And I see this as a truth that is going to last for a lot of time. And this is what Dr. Lalit has said, that in this sense, a bone marrow aspiration, you see, it's your biology can be not the answer, but one answer to this. And in this sense, sir, what is your experience? I don't want to change the subject, but my Indian friends, they talk a lot. Dr. Ildeu wants, if he knows something, about bone marrow aspiration in pseudoarthrosis in many long bones around the body. I know nothing about it. As a super trauma surgeon, sir, much more than I do in many other parts of the body. What do you think about bone marrow aspiration for some kinds of non-unions? This is a nice question, sir.
So who is taking it?
No, you. Okay. You.
So we have been using it, and it has a promise and a place in the hierarchy of solutions available for complex non-unions.
Okay.
Meaning that you are not sure that it is uniting at the pace what you want, or the patient has already failed a few attempts of reconstruction and another surgery is a big surgery. So it is a solution which both the surgeon and the patient are ready to take because it doesn't get an anesthesia. So you can perform this without an anesthesia, and we don't know, probably multiple pricks with the needle break the fibrosis a bit, increases the vascularity where it was all fibrous tissue. And then when you add on those osteoprogenitor cells, and there is a small hematoma which has formed due to pricks in the fibrous tissue, maybe that's helping. So we can't say a yes or a no. We discuss the same with the patient, that this is a non-invasive option, which can probably allow you delaying another surgery. And if you're very lucky, you might get away without any surgery.
Yeah. So what you're meaning, sir, is that the morbidity of the procedure is very less. The morbidity. And you see, very interesting that you were saying that it's not only biological, but by a little bit mechanical, by breaking fibrotic tissue and inducing some hematoma. This is something nice, but Dr. Ildeu wants to speak, I don't know about it, or something else, or both.
Yeah, well, we have used this bone aspiration to these pseudoarthrosis, non-unions, but in my opinion, my experience, it does not work very well if the osteogenic cells does not have a support, a proper support. Otherwise, the gravity will clean it, okay? So I think it's important to use it, not in a well-established non-union, just before that, when you do not have such a lot of fibrosis. So in my opinion, we need a compartment to keep these osteogenic cells for them to work. And that's my experience using it in non-union of the shaft of the humerus. But I would like to say a little bit about osteointegration, because it was the question before this topic, because we are writing a chapter about these metal backs, because it was very interesting, because in the beginning of the metal back, 20, 25 years ago, when the French guys, they started to do metal back for shoulder replacement, it didn't work. Didn't work at all. And it was interesting because in England, it was working very well. So as the French guys, they dominate the shoulder surgery in the world. So the concept is that the metal back does not work because the French metal back didn't work. So it's a nonsense, because nowadays the industry put all of the efforts in metal back for reverse prosthesis. So if it does not work, why they would put such a lot of money on it? So it's something interesting to understand, that sometimes the history is written by some guys that does not have good results, and all the world, the rest of the world starts doing it. So another concept that I have, and I would like to share with you, that in anatomical shoulder, we do not have compressed forces, as you told, like in hips or knees, but in reverse prosthesis, we have a lot of compression forces. So in these cases, we have a proper environment for the metal back and for bone ingrowth to the So I understand the metal back works better in reverse prosthesis than in anatomical prosthesis.
Yeah, Dr. Lalit, any comment about it? Because together with what Dr. Ildeu has said, what I've been seeing, we are talking about biology here after, is that you see in reverses, the use of cement has been basically abolished. So, and we have been very happy about it. And the ingrow about, I would say, the glenoid component has been quite nice, but the problems would be really on the defects. And talking about defects, there is a very good friend of us who lives quite, I would say, quite closer to Dr. Ildeu, which is Dr. Mota, Dr. José da Mota, our good friend. He's asking me through WhatsApp, Dr. Lalit, what's your experience with bony banks? I'm sorry, in spite of allografts. He wants to know that, and then he has another question for Bruno. You deal with complex tumors. Your experience with bony banks, if they are available to you, but you are in Delhi, you are in a big city, you are a reference. What do you think about that, sir?
Bone bank definitely has a huge role if you're doing tumor surgery, because the defects are huge and they are difficult to cover up by autografts. We have been using frozen bone at -70 freezers in our institute for around 20 years now, and they serve as a very good solution where the bone substitute, the bone graft is a big requirement, like a huge giant cell tumor of the distal femur, where the graft size required is huge. We put at times even 5 femoral heads sort of meshed and packed into the area. And when we do resection arthrodesis around the knee, where we take the contralateral normal autograft fibula and the ipsilateral fibula, there we add on the allograft with the patient's autogenous patella. So in bone tumors, definitely where we are using it in addition to the biological grafts of the patient itself, meaning that the autograft, the allograft is actually giving you a scaffold, and the mixture of the autograft gives you the cells and the other progenitors which need for bone healing. So the experience with deep frozen allograft in bone tumors is good.
Oh, it's good. And
yes.
What about the radiographical follow-up after, I would say, 4 or 5 years? Do they disappear or not?
They do disappear depending upon what indications you are using. So, for example, if there is a resection arthrodesis with a long nail in the leg, and the patient needs to go for a chemotherapy post-operatively. For example, it's a Ewing or an osteosarcoma. Those are the patients where the resorption is even faster. And if it's used in a giant cell tumor, the resorption does occur, but it is slower. But then for such a large filler gaps, we are not using it as a structural filler, but we are just using it as a filler gap in addition to the normal autogenous grafts. So they do resorb, but it will depend upon what indication.
No, I understand. And see, as we are discussing so difficult things, because these are difficult to me too, Dr. Mota is asking for Bruno, but Dr. Lalit can say, and I know nothing about it. What do you think? What do you think about navigation? Navigation. Do you have any experience in navigation?
I'm going to answer very quick. What we are doing with augmented reality actually is trying to create our own navigation system, and that's what we did not done yet, but we are intending to do in the future. So what augmented reality can bring for us as surgeon, as it's a customized navigation for every surgery, for a fracture, for a distal radius fracture using K-wire, we can possibly use navigation technologies with augmented reality. And that it's the near future that I imagine, and I'm working on that actually.
Okay, before we finish, we are finishing 10. But one question for Dr. Lalit and one for Dr. Ildeu. Dr. Lalit, your clues on navigation, this is a mystery to me. What do you think about navigation? Because this is huge in knee arthroplasty. Do you see any fusion of this with augmented reality? Dr. Mota is asking. This is it's difficult for me to understand the question, but I want to see if you have an answer, sir.
The answer is yes. I think that's a very, very exciting future, because navigation again works on the patient's CT scan, and our technology is working on CT scans. So it is enhancing the guiding of the surgery. So if you look at the literal meaning of navigation, it is guiding. At times I label my 3D printed guides as navigation guides. So the place which we are seeing that it might work is positioning our 3D printing guides. So if we have a navigation as a support to correctly position our guides, that is most important in tumor resections. Like if you have a pelvic tumor and you want to place your guide in a very perfect position so that the margin is free of any tumor, that 1 millimeter of error on placement of the guide can be helped by the navigation. So the fusion of AR and navigation with 3D printing and virtual planning is definitely a very good sort of a composite, which will even increase the precision further. And I want to just add one thing to the previous answer of bone grafts. We've been having some exciting experience with induced membrane. Especially in cases where bone tumors, in stage 1, we are giving a cement spacer, and then we are revising that cement spacer once the chemotherapy is over. So there is a phenomenon of induced membrane. We take out the cement, the membrane is there, and that we pack with mixture of allo and autograft. And that gives a very, very exciting solution.
Okay.
A very quick comment, Sergio.
Yes.
For me, navigation and 3D printing are different outputs from the same technology, which is planning your surgery. You plan your surgery, you can do a 3D printing, you can do guide, or you can do navigation. But always starts with what we are doing today. It's planning our surgery, doing exactly what we want. So if you're going to have a jig, it's a jig. If you're going to do it virtually, it's virtually. But always starts with the same step. And Dr. Lalit said, just planning with our CT, our procedure.
Okay, you see, we are 2.5 hours. So I have one last question for Dr. Ildeu. Another shoulder guy is asking me, and this is a good question. When you have a complex glenoid and you don't have a 3D planning, how do you manage that? This is a good one. Bruno can talk. In my opinion, the answer would be a 3D CT with suppression of the humeral head. I cannot think about any other stuff. But you don't have a 3D planning of a difficult glenoid and just a CT. How do you manage that? I would do suppression of the humeral head, and that would be my best. But what do you think about that, Dr. Ildeu and Dr. Bruno? This is our last point. We are not listening to you.
Sorry. Based on what I have said in my presentation, if we have more than 10 degrees of retroversion, we're not supposed to try an anatomical shoulder replacement.
Okay.
So if you do not have 3D software to plan your surgery, you have to use 2D, and you have to use the axial axis of the CT to calculate the Friedman angle. So based on Friedman angle, you are going to know to plan a reverse or anatomic shoulder replacement. And it depends on the native glenoid curvature. So I use the native glenoid curvature, which is the anterior part of the glenoid, to understand how much I can rim without having to put some augmentation. So if you do not have a wedge glenoid or base plate, you are supposed to use bone graft. So that's what you have at the moment. So you have to use it. That's what I do when I do not have these other technologies available.
Okay, okay. Bruno, any clues about it before we finish?
I'm more drastic, of course. I'm young, so I'm not. My drastic question for me, we have to have a CT. So if you have a CT, you have the 3D. That I just showed you. So if you have a CT, you have the 3D. You just need to go into your computer in 10 minutes. You have the 3D model. So for me, if I don't have the CT, I don't do the surgery. That's
it. You see, so the message.
I'm not experienced as Ildeu, so I did 100, 200. So I don't have the sixth sense as an experienced surgeon has. I don't have that. So I rely on not on the technology. I rely on my planning. The technology is just to do my planning. So today, for me, I cannot enter in an OR room, but it's only my opinion without planning aortoplasty. Of course, a fracture, it's different. But aortoplasty that I do very few amount, if I do not plan, I'm feeling that I'm harming my patient. But that's
okay. But see, the message here is that this technology is not a dream. It's possible. I know that there is a learning curve, but there is a learning curve for everything. You know, there's a learning curve for everything. So we must, I would say, rely on that. And you see, but you can do many things. Last year, I received a gift. I'm very happy to show. This is Shoulderplanet in 3D that I received as a gift from Bruno. So you can do a lot of things according to your creativity. So see, folks, we are more than 2.5 hours. I guess that it's a good time for us to finish. I would really thank Dr. Ildeu, Dr. Lalit, Dr. Bruno. I just would tell you that this is difficult to me, but we have to open our minds to new stuff. And you start to get old. There is a popular dictum that says you start to get old when you think you know everything. So we know a lot of things, but there are 10 times more things that we don't know, but we are eager to learn here. And it's a pleasure to have people with so many experiences, Bruno, Dr. Lalit, opening our minds and seeing beautiful things about the shoulder like Dr. Ildeu. So before we finish, I just would like to hear your honest opinion. Bruno, Dr. Ildeu, Dr. Lalit, and then we can finish. Bruno, your final statements, please.
Oh, thank you for being here. And what we hope here is not to everyone start in the next second doing that, but knowing the technology, knowing that that can be done with no cost, not effort, lots of effort, but at least no cost. That can be done. That's our objective for today.
Or very small cost, very small cost. That's not much.
Small, sorry, very small. Yes.
Yeah, very small. Dr. Lalit, thank you, sir, a lot. I hope next time I go to India after coronavirus, I can meet you. Okay, Dhanyavad, namaskar. Your final words, sir. It was an honor to have you here, but your final words before we finish. And I'm very thankful to you, sir. Just for you to give your final statement, sir.
It has been an honor to me also to interact across the globe, and definitely I will land up on your side someday and see your beautiful country. And I think Bruno and me would have a common message for everybody that both of us are 3D enthusiasts. So if anybody who is listening wants to have any help on anything, our emails are there and we are always ready to help without any cost, because we are maniacs and we are enthusiasts on this technology. So ready to help. It is easy, and the best way of learning it is by doing it yourself. Thank you so much.
Okay. Bruno, you see, a lot of Indian guys, they are always talking to me. And if they want to talk to you, can I give them your email? Or I'm not sure if I can do that, but if I can, because you see, I want to connect people. I want to build bridges, and if you allow me, I would do that as long as they ask me to, because I think that knowledge is to be shared. Knowledge is to be shared. That's something, that's a mantra. Many mantras in India, but this is a mantra to me. Okay. And Dr. Ildeu, you are a veteran here with me. It's a pleasure. I know you are helping me too much in this journey. Your final statement, my good and outstanding friend.
Well, it's our fourth webinar together. Very stimulating and advanced topics. So it was really a pleasure, an honor to be part of it with you and our very expert friends. Thank you very much for it.
Okay, so before we finish, just two statements. I would kindly ask our friends if they want to get experienced in shoulder and elbow stuff and some things about orthopedics, to subscribe to my YouTube channel, youtube.com/shoulderplanet. I'm putting a lot of videos this year. I'm very proud to say we are in November. I have already put 42 videos. It's a lot of efforts. Some videos has 10 minutes, some videos has 40 minutes almost. It's very difficult, but I love to do it. And if you subscribe to my YouTube channel, as long as you want it, that's a big help to me. And I really want to say thank you in my name, Dr. Bruno, Dr. Ildeu, and Dr. Lalit, to Ortho TV, because without them, nothing of that would be possible. They are giving us a lot of support, and they are giving us, and Dr. Ildeu, a lot of autonomy, and I would say freedom to create a lot of things. And this is because of trust and we have nothing in life if we don't have trust. So I'm very hopeful about that. Before we finish, I don't know if Dr. Ashok or Dr. Dheeraj, if they are online and they want to say something before we finish. Dr. Ashok, I'm not sure if he's online. Are you there, Dr. Ashok or Dheeraj? Okay. Ashok is the king. Now we have the king. Thank you.
Thank you very much. I think this was a very, very interesting session. And I don't think I've seen this technology being presented as it was presented today live on a webinar. So hats off to you, all of you, for planning this and executing it to perfection. So thank you very much.
Okay. Thank you a lot. I just want to tell you guys that I have already spoken to Dr. Ashok and to Dr. Dheeraj. We are planning a fifth webinar about frozen shoulder with Dr. Daniel Moya. That is a beautiful physiotherapist from India, and we are much probably asking someone from Spain. So we will have 4 countries: India, Brazil, Argentina, Spain. I'm very happy to build these bridges. That would be impossible without Dr. Ashok, Dr. Dheeraj. Thank you a lot. Namaskar, namaste to all of you. And I guess that we will finish this now, okay? Okay?
Thanks.
Okay, thanks a lot. Bye-bye. Bye-bye, folks.